Department of Psychology and Social Sciences. So welcome, madam, and also I welcome today's chairperson and my friend Dr. Raghavendra Nayak, Professor of Psychiatry at DIMANS, Harvard, as who will be chairing the session. And I'll be welcoming the today's moderators and the pillars of this program, Dr. Bhimsen Tekliki and Dr. Vishwas Adward. And also I welcome Mr. Sriram of Icon Laboratories and all the postgraduate students for this webinar series. This is the fourth webinar series, fourth session in this webinar series, Psychotherapy Primer. So as you all know that many of the students who was studying post-graduation in psychiatry outside the NIMANS may not be exposed to the psychotherapy procedures. So with this in the mind, we wanted to enlighten all the psychiatry postgraduates as well as other mental health professionals with basic psychotherapy principles. So far we have covered on CBT, then behavioral therapy methods, and also MET. And today we are going with dialectical behavioral therapy, which is the toughest, as many people feel. And many people don't want to work with the people who have borderline personality per se. So, and that too, doing a DBT is a little bit difficult one for the many people. So we have an expert today, Dr. Alafia. So I welcome and over to the moderators. Thank you.
Thank you, sir. So the chairperson for today's session is Dr. Raghavendra B. Nayak. He is an alumnus of NIMANS Bangalore, currently working as Professor of Psychiatry, Harvard Institute of Mental Health and Neurosciences, DIMANS, Harvard. I welcome you, sir. I request you to introduce our speaker for today's session and carry out the scientific session.
Thank you, Bhimsen. Thank you, Vijay, sir. First, I'd like to thank IPS KC for giving me this opportunity to moderate this session on psychotherapy primer. I would like to introduce today's speaker, Dr. Alafia Jilani. She is the Assistant Professor of Psychology in School of Social Sciences, Christ University Central Campus, Bangalore. She is an RCI licensed clinical psychologist and psychotherapist. She has an experience of over 7 years as a clinical psychologist, and she routinely practices CBT, DBT, MBT, and trauma-focused interventions. She is also a guide for postgraduate students and also PhD students. Her area of interest are psychotherapy process, personality disorders, mental health of practitioners, trauma-focused intervention, and other area is effectiveness of therapy across the different psychiatric disorders. We are happy to have you, ma'am, here for this evening, addressing the mental health professionals, especially the postgraduate students of psychiatry and other psychology and social work. Will be all the attendees will likely to be benefited by this session on dialectical behavioral therapy. Over to you, ma'am. Thank you.
Thank you, Dr. Raghavendra. Before I start, I would like to thank the Indian Psychiatric Society Karnataka chapter and all the members who invited me. I consider it an honor because a lot of them are people who I've learned from, and also some of the previous resource persons are people who trained me. So it feels very good to be here. I'm very happy that dialectical behavior therapy and personality disorders are also gaining a lot of attention. And I think that in today's session, there'll be just an introduction to some of these challenges that we face while we engage with clients who have, say, borderline personality disorder. So though today's focus will be on borderline personality disorder and DBT, I will share a lot of material later for those who are interested, who can go back and read on how you can apply DBT in other disorders as well. So let me start with the presentation. So when we say dialectical behavior therapy, the term dialectics basically refers to a certain opposing force or two polarities that need to be balanced. And we know that someone with BPD pathology has instability in various areas, such as relationships, work, and so on. So one of the reasons why dialectical behavior therapy came up is because the founder of this particular school of thought was Marsha Linehan. Basically, herself had borderline personality disorder, and she came up with some of these skills as a way to cope with some of the difficulties that she was facing. So before we start, let's just look at what DBT is. We know that dialectical behavior therapy, just like cognitive behavior therapy, is a skill-based approach, which means that we're focusing a lot on teaching skills that someone has not had the opportunity to kind of learn. The dialectical behavior therapy is based on the biosocial theory which Linehan gave, which basically talks about two major aspects which cause borderline pathology, that is biological factors and social factors. As we all know, coming to biological factors, any mental health illness, there is a certain predisposition that people have which causes them to go on and develop personality disorders. It's also found that clients who have borderline pathology are highly vulnerable, very sensitive and reactive, have intense emotions, and have difficulty managing their emotions. An example of this would be someone coming from an alcoholic family. Other social factors could be certain things that are happening in the environment, like an invalidating environment, difficulty at home, school, peers, and so on. Now, coming to learning how to conceptualize any client that has borderline pathology or anything to which DBT is sensitive, is one to understand that emotion dysregulation is at the core of any kind of personality disorder, mainly borderline. So because this is a very pervasive problem, when we look at our clients who come to the OPD, we generally see that they come when they're highly dysregulated or they're highly impulsive. Now, this dysregulation is like a combination, because of a combination of different things like genetics. Like if someone has a parent who has a borderline personality disorder, there's a 40% risk for them to also kind of go on and develop the same. We also see that when a mother, for example, who's pregnant has borderline personality disorder, the chances of the child also developing is much high. Plus, the mother also might pose as a risk with respect to how she's bringing up the child. So if the mother is highly dysregulated, the chances are that the child also does not learn how to regulate himself or herself. So invalidating environments, like I said, are one of the reasons why they go on to develop this pathology. It's also maintained by an interaction of biological factors plus environmental factors. And because someone with a predisposition already is sensitive to certain things that happen in the environment, when there are stressors, it takes them a very long time to come back to baseline levels of functioning, which is why when we start therapy with someone who has borderline personality, for example, they take a minimum of 6 months to stabilize. And the full dose of therapy for someone with BPD is 2 full years of once weekly therapy. And that's the format that DBT follows as well. So basically, DBT uses a whole range of skills. We have already learned about CBT, so I won't go through that. We'll be using some parts of CBT, such as behavioral analysis, problem solving, exposure, contingency management, and so on. But the thrust of DBT is skills training in 4 different areas. Now, why do we need a separate kind of a intervention for this kind of pathology? The reason for this is that when DBT was developed, it was developed for highly parasuicidal patients. That means clients who had a lot of self-harm behaviors, and CBT was not enough to cater to those needs. And generally speaking, if you look at the format of CBT, it does not focus on distress tolerance, it does not focus on suicidality, crisis management, and so on, which is why DBT kind of came up. So in DBT, we teach them specific coping skills to reduce the amount of triggers and to also reduce the time that they take to move from emotion dysregulation to baseline. So that is the reason why DBT kind of was developed. So DBT is not different from CBT, but it's more like an offshoot of CBT, which is a more complex form of CBT that's done. It's usually adapted for behavioral disorders. Any disorder that has emotion dysregulation, like their substance dependence, binge eating, eating disorders, those who have suicidality, DBT can be used with any of these clients. So the basic assumption on which DBT is kind of based is that the core or the central issue is skill deficits in the area of emotion regulation, which is why some of these interventions are designed, right? So now let's look at what are those 4 modules that DBT offers, and how I'll give you some tips as to when you're using these, how do you implement that with each of these clients? So before we move on, the term dialectic, like I mentioned, refers to an argument that has two parts to it, the thesis and the antithesis, which means that there can be opposites, like there can be love and hate, but both can be true, both can be comfortable, uncomfortable, and so on. So this walking the middle path, or this balance that we all are able to so easily make, clients with this kind of pathology are not able to make. So the entire skill and the module that we have is designed to help clients become okay with the gray areas and not stick to polarities. That's what the dialectics basically mean. So in the process of therapy, what we would do is we would help them see different perspectives and not just hold on to one explanation that comes very easily to themselves. So what do these dialectical dilemmas look like? So our clients might end up in relationships, romantic relationships, for example, where they're either too independent in the relationship, they don't know how to be interdependent, or they might be extremely dependent on their partner to meet their needs, where they're not able to just manage any of their emotions on their own. It can also be about boundaries, where the boundaries are too strict. So even if someone advises or gives them some opinion, they might get very upset and immediately move out of the relationship. Or the boundaries might be very loose, where they are treated like a doormat and they just don't know how to set that boundary, and they're very people pleasing. So it's also possible that whenever there are problems, they might end up looking at these situations in a very light-hearted manner, or they might take it very intensely. So these are just some dialectical dilemmas that you will see while you're working with clients. There are different formats of DBT that are available for adolescents, for working with mothers specifically who are in the prenatal period, for adults, and so on. So more or less the format is the same. So coming to the benefit of DBT skills, who can you actually use this with? So basically young people who come with self-harm behaviors, irrespective of a personality disorder diagnosis, they can work with DBT. It also works very well with clients who have substance dependence, suicidality, cutting, burning, or other self-injurious behaviors, and eating disordered behaviors. So if you look at all of these disorders involve high levels of impulsivity, high levels of disinhibition, and emotion dysregulation. So any of these in any of our clients, DBT is something that can be used. Now, if you look at CBT, if you look at person-centered approaches, the therapist is expected to be of a certain personality type to deal with these kind of disorders. So who is the CBT therapist, for example? A CBT therapist is someone who is able to access the more rational parts of his or her own mind and is able to challenge the client so that they can become more rational in their thinking. Whereas a DBT therapist is not looking to help the client become rational, but they're helping the client learn the balance between everything that they're doing. That means learning how to accept situations as they are, but also learning how to bring about a change. So there's this concept that's very popular that's called radical acceptance, which basically means that you realize that other than your own behavior, any other experience, is not in your control, and that once you accept it, it becomes much more easier to change. Now, what are the other qualities that a DBT therapist must kind of come up with? Before I actually go into that, I have a quick question for the audience here. Can you quickly tell me what is your perception of clients who have borderline personality disorder? If you can quickly type in the chat box, please. So my question is, what is your perception of clients who have borderline personality disorder or any personality disorder? Yeah, how do you perceive these suicidal patients? You like them, you don't like them, you find them difficult, you find them problematic? They are challenging to maintain engagement with. It's hard to change their behavior, they're difficult to handle, they have to be constantly they're constantly invalidated, discredited. Okay, it's challenging, right? So we are already walking on eggshells when we know that this client has a personality disorder diagnosis, and someone's also saying that it's difficult to come out. It's a frustrating experience as well. So when we already have this perception of someone who has a personality disorder, we don't know what's going to, kind of trigger them. So as a therapist, one of the things that's going to be very difficult for us to imbibe while we start working with these clients is to have a non-judgmental attitude towards the illness itself and to be compassionate with them, because some of the behaviors might seem manipulative or some of the behaviors might seem deliberate in nature, which makes it very hard for the therapist to empathize with the client. So in order to kind of overcome this, one of the things that most DBT therapists are recommended to do is to do DBT themselves, so that they are able to see what are their own shortcomings, what are their own difficulties and challenges, so that they're able to kind of empathize with the client as well. And often, if you're doing long-term work with clients who have any kind of a personality disorder, it's important that you also do DBT for yourself, do some of these skills, so that your resources are not constantly being demanded by the clients, right? So this is what is the expectation from someone who wants to be a DBT therapist. Now coming to DBT functions, very quickly I'll tell you what are those things that ultimately as outcomes what we look at. One is to enhance their capabilities in relationships, improving their motivation to change, and whatever skills that you're teaching them, they get generalized to the environment and they start practicing some of these skills, learning how to structure their environment, and enhancing the therapist's capabilities and motivation to treat these clients, right? So those who are seeing clients with borderline pathology, very important for you to also constantly seek supervision, because it can be very draining and demanding to work with these clients. So some assumptions that DBT has about clients is that patients are doing their best, they want to improve, they want to be motivated, and sometimes it's very unfortunate that some of our clients have to go through very bad and traumatic experiences because of which they've developed this pathology. So nobody wants those experiences, but then we are asking them to solve some problems that they have not caused. So sometimes it does feel unfair and it seems very sad for them to work on that. Also, clients who are suicidal might have a lot of difficulty verbalizing that. So making sure we are making space for that. And patients have to constantly be, learning new behaviors where they're able to apply that in all contexts and so on, right? We'll move, I think it's more or less the same thing. Coming to the stages, basically the entire stages of DBT treatment can be divided into four stages. The first stage, almost with any client who has impulsivity dysregulation, is to stabilize and bring about behavioral control. This can be done in the form of having an informed consent form, having certain things mentioned about what will happen when there's an emergency, whom should we contact, what should they do when they're suicidal, what should they do when they're engaging in self-harm and so on, and giving them numbers of the emergency and all of that. So this would be the initial intervention we do. We also reduce life-threatening suicidal behaviors, reduce therapy interfering behaviors. Now, therapy interfering behaviors are nothing but behaviors that come in the way of a good therapeutic alliance. So sometimes clients might end up canceling appointments at the last minute. They might test your limits. They might ask you, am I your favorite client, or is there someone else who's a more favorite client? Or they might come for the sessions but then not do the homework that's given. So these are all therapy interfering behaviors. And the best way to deal with this is to talk about them initially itself, that if you start coming late, like if you miss 30 minutes of the session every week, then you're not going to be able to recover like other clients would. Also, decreasing quality of life interfering behaviors. Generally, we find that clients who have borderline pathology also have comorbid issues like insomnia. They're not able to regulate their professional life, personal life, and so on. So just doing some practical strategies that also sets up a system in place so that they're able to manage some of these things and also increase behavioral skills. So that's going to be stage one. Usually it takes about 6 months for them to reach stage one, but some clients who are not as severe can just take about 1 or 2 months to reach there. Stage two is to achieve ordinary happiness and reduce unhappiness. which basically means that we help them see, what are the things that they actually enjoy, and move away from things that are not, kind of helping them. All right. Stage 3 then is to reduce ongoing disorders. We also know that borderline pathology is comorbid with depression, anxiety, and so on. So making sure that we're treating those other things also that are along with that. And stage 4 is to resolve that sense of incompleteness or that sense of void which they have and basically achieve joy. Though stage 1 is very behavioral, stage 2, 3, and 4 takes time. It should take about 2 years for you to actually get there. It's very vague, but while I'm discussing about the modules, I'll tell you how you can go about doing this. Now, coming to the 4 modules, there are 4 different modules that we can kind of use. One is mindfulness, distress tolerance, emotion regulation, and interpersonal effectiveness. These are 4 modules, and I'll be talking about them in detail. There's a 5th part to this, which is walking the middle path, which is one of the most important components. It does not have to be done in the end, but it can be done anywhere in between during these modules. So we'll start with mindfulness. Now, coming to mindfulness, basically this was a third wave therapy that came in through the Vipassana meditation, which is an Eastern philosophy that talks about how when you pay attention to your experience and you allow it to come and go, the intensity of the suffering automatically comes down because emotions have a time limit. They don't stay forever. So if you can sit with it and be mindful with it, then it becomes much more easier to deal with it, right? So usually when do we use mindfulness? We use mindfulness when there is some kind of self-dysregulation that the client has. So this self-dysregulation can come in the form of these 3 things. They might have a lot of identity confusion. So some of these clients might end up changing different careers. They might start changing their religion. They might keep shifting from one city to the other because they're not exactly sure who they are. They also tend to be highly suggestible. So if they're meeting someone new and they're impressed by that person, they might end up saying, okay, I want to be like this, and so on. There might be a chronic sense of emptiness they have. So that the client will describe and say that I feel like no matter how many relationships I have, I still feel like I'm alone and I feel a part of me is still incomplete. There might also be a lack of awareness of their own thoughts, emotions, and behaviors. So when you see that your client's profile matches this, that identity and sense of self and all of that is affected, mindfulness is the first intervention that we can kind of practice. So generally, you will find that when clients come in distress or they come in a crisis, they are not noticing their thoughts and they get very overwhelmed very easily, which basically increases the levels of anxiety, depression, and anger. They might also engage in impulsive decision making, and they might behave in a reckless fashion. And because they're constantly worrying and ruminating, they might not be able to enjoy whatever experience they have now. All of this basically leads to a heightened state of stress, and there might be an absence of skill because of which they're not able to manage things. So what does DVD talk about in mindfulness? So regularly when we're doing mindfulness meditation, it looks like Vipassana meditation where you're sitting in a place, closing your eyes, and just paying attention to all the experiences that you have. So when you're introducing mindfulness skills to your clients, some clients will just say that I can't sit in a place and do meditation. I don't know if it will really work for me or not. So one good way of explaining to them about how the mind works is that we do an experiment, which I'm going to also ask everyone who's here today to do it. So what I'm going to do is I'm going to make you do 2 experiments. It's just going to take us 2 minutes to do that. So I want you all to settle into a comfortable position in your chair and gently close your eyes. So for the next 1 minute, I want you to think about a camel. It can be about anything related to the camel. So for the next 1 minute, just think about a camel. Okay, you can open your eyes now. Can you quickly type in the chat box and tell me what you thought about? Neck and hump on the back, okay. Jaw movements, okay. Camel has 4 legs, okay. Anything else? Did you think about anything else that is associated with the camel? Like it's in a desert, it's moving. Yeah, it lives in desert. Okay, all right. Okay, thank you. Now we'll move to the second part of the experiment. It can manage without water for long, all right. Okay, so now settle back again into a comfortable position, gently close your eyes. For the next 1 minute, I don't want you to think about a camel.
No, first thing is that whatever medicine is there now, most of the medicines is of depression only. One Palip XR, that is for psychosis.
Okay, you can open your eyes now. Can I have some quick responses in the chat box? What did you think about?
Okay, and the Palip XR doesn't causes any kind of depression. So here maybe she has depression, okay, along with schizophrenia, okay, and she needs. So you are not taking all the therapy sessions.
I thought about camel sometimes. Couldn't avoid thoughts. Thought about horse. Okay.
You continue with that.
Not thinking also needs effort. Thinking about work.
You are teaching her skills only.
No thoughts. First few seconds, it was all about the camel. All right. Okay, great. Right. So now, when we do this experiment, what we're able to understand is that it is the job of the mind to produce thoughts. And if you tell your mind that I should not think about something or I don't want to think about this, it is likely that you'll end up thinking about it and you start ruminating just because you said, no, I should not, right? So this is what is a judgment. So when someone is making a judgment and saying that you're not allowed to think about a camel, that's when the thought comes back as a boomerang. So this experiment can be used with your clients to explain to them how the mind works and that the thoughts are not under our control. The thoughts come and go, but just because thoughts are coming, it doesn't mean you get distressed, right? So because I said don't think about a camel, many of you would have thought that, okay, I'm not supposed to think, but then I'm thinking about it, but I want to move away. So it causes a certain emotion, right? So that's exactly how our clients also feel when they are overthinking about something. So one of the ways mindfulness is then going to help our clients is to become non-judgmental towards your own thoughts, pay attention to the task that has given, and effectively, be mindful with whatever task, whether talking to someone, whether sharing your experience, sharing about your emotions, and so on. So mindfulness can be taught in two ways. One is the what skills, and second is the how skills. So what are these skills? One, they are allowed to sit down and just observe their thoughts as they come and describe them in a non-judgmental manner and participate in the thoughts, but they do not react or respond to those thoughts. They just sit and observe as it comes and goes. So with this practice, what happens is, rather than reacting impulsively whenever they feel dysregulated, They just sit down with their thoughts and allow the thoughts to come and go, as if they're sitting on a beach, for example, and watching clouds pass by. They're not making any judgments, but just allowing the thoughts to come and go, knowing that there is something that's disturbing them, and that it's all right if the thoughts come in. They don't have to do anything to kind of, get out of it. So that's what the mindfulness skill list is. After the presentation, I'll also be sending across more materials and workbooks, which will give you more clarity about how to conduct mindfulness. So like we already talked about, there are what and how skills, and you'll basically learn more about how to observe your thoughts, how to observe your emotions, how to describe them in a non-judgmental manner, and how to mindfully pay attention to whatever task is being done, and being non-judgmental and effective in the way you're using the skills. So that is mindfulness skills. There's another important aspect of mindfulness which we also have to talk about. I see there's a question. I'll come back and respond to that a little later. So there are, according to DBT, there are 3 states of mind. We all have these in different, percentages. You have something called the reasonable mind, which is like the cool mind, which is very logical and looks at things very practically. And you have the emotional mind, which is the hot mind, which basically tells you what is not feeling okay and so on. And this overlap that we see in between is what we call the wise mind. So a combination of both rational mind or reasonable mind plus emotional mind is what is wise mind. So ultimately, when you're educating your patients, what you'll be telling them is that mostly when they're feeling dysregulated, they're using the emotional mind. Whereas when they're not dysregulated, they're using the reasonable mind, right? So if they're using this in polarities, like they're using only emotional mind or reasonable mind, you might have to help them, use a combination of both and use what is called the wise mind, where they are practically handling the situation. Plus, they're also taking care of their emotions while they're doing that. So this is generally a very nice activity which clients also like, where you explain to them about reasonable mind, emotional mind, and wise mind. So one example of using this in your session is if a client comes and says that I'm going to leave my family because nobody loves me. That is the emotional mind that is speaking. Okay. So once you educate them, you can also say, okay, that's your emotional mind speaking. Can you tell me what does your reasonable mind say about it? So the reasonable mind might say that my mother or father were not able to be there for me at this point because they themselves were going through some difficulty. So probably that's why they were not able to kind of be there with me. So that is like the reasonable mind. Wise mind would sound something like, I'm upset about the fact that my parents don't understand me and they're not there for me. But I'm also able to understand that they might be dealing with some of their own difficulties, because of which they're not able to be there. So that is something like the wise mind. I think there are 2 participants who've raised their hands. I think Mikhail and Ashita. So Mikhail, you can go first, and then yes, Mikhail. Okay. All right. So I move ahead in that case. So we've kind of summarized this already. Like I said, a reasonable mind is a cool approach to problem solving, and emotional mind is a hot approach to problem solving, and wise mind is a synthesis of both of these. So that is our first module. Coming to the second module, that is interpersonal effectiveness. So generally, how does interpersonal dysregulation actually present in these clients? It can be in 3 different ways. One is chaotic and unstable relationships. Chronic family disturbance and social isolation. So unstable relationships can be either with parents or romantic relationships, friends, and so on. There might be a chronic family disturbance, which means that there might be a very toxic environment at home, and they might be socially isolated because of the emotion dysregulation that they have. Many people do not want to be with people who might show intense emotions, which is why they might end up having a much smaller circle. Now, coming to interpersonal effectiveness skills, there are different ways of teaching them interpersonal effectiveness. So when you're doing a case conceptualization with clients, you have to see what are the interpersonal difficulties the client is facing. Some clients will have difficulty in being assertive, so they might either be aggressive and don't know how to ask for things in a diplomatic manner, or they might be absolutely submissive, where they'll just do whatever anyone tells them. They might also have difficulty in problem solving. So when they have some difficulty with a relationship, for example, they might not know how to go about solving it. So these are two areas that we explore. Now, when it comes to sharing about how you feel about an experience, or if you've had an altercation with a parent, for example, and learning how to get what you want, there are two aspects in interpersonal effectiveness. One is relationship effectiveness, which means we learn how to be effective in our relationships, and there is self-respect effectiveness, which means that any interpersonal conversation that a client has, at the end of the conversation, they need to feel that the sense of self-respect is preserved. Often we find that because they're so upset and angry, they might end up losing a lot of self-respect because they act in ways that is not socially desirable. They might end up screaming or shouting at their partner or their parents. They might end up breaking things and so on, which basically leads to diminished self-respect, and they also end up feeling very guilty. So when it comes to self-respect effectiveness, we teach them certain skills like Dear Man. So Dear Man is an acronym for a technique of learning how to describe emotions without accusing the other person. So Dear Man stands for describe, where they describe facts and tell the other person what has happened. Express basically means that they express their feelings using I statements. Like, for example, I felt bad when you did not acknowledge, all the work that I do at home, for example. Assert is to tell them what is it that you want, saying that if every time I end up doing so much work at home and that work is not appreciated, I'm afraid that I'm going to stop taking equal responsibility at home. So that is being assertive. Reinforce is to say that I understand that even you have played a major role in the house and you contribute as well. So I really appreciate that you're able to do that. Appear confident basically means that while you're having this conversation, you're not having it because of fear or because of resentment or anger, but you're appearing that you're confident about what you're talking. N stands for negotiate, where you negotiate with the partner or with the parent and say, I am willing to do this much, how much are you willing to do from your side? Being able to be flexible and learning how to make a request, learning how to refuse when someone is requesting, ignoring certain things and so on. So these are some skills with respect to self-respect. In relationship effectiveness, it is important that no matter how angry or upset even their partner is, they continue to remain gentle. They continue to remain interested in what the partner has to say. They're able to validate their partner, and they have an easy manner. So that no one's really getting extremely angry, upset, but everyone's just trying to sit down and have a conversation about things. It's also important that they use this acronym called FAST, where they're fair with whatever arguments they're putting forth. And they should not be one-sided, but they should also take into account what their partner wants and so on. Stick to the values. So we all have different value systems. So sometimes we are not okay to compromise that with, family, partner, friends, and so on. So sticking to the value and also be truthful and not make false accusations and so on and so forth. So these are some of the things that can be useful when you're looking at interpersonal effectiveness. Moving on quickly to the emotional regulation module, which is one of the core elements of working with BPD. How do we see dysregulation in clients? Usually you find that they're extremely vulnerable or they're not vulnerable at all. They might have affective lability, so the moods are constantly changing. They might have anger issues, and they might have a consistent negative emotional state or negative affect. So these are things that we see with our clients. So the goal of emotion regulation module is not to get rid of their emotions, but to reduce the emotional suffering. And we'll take a look at how do we do that. So one of the ways of doing this is to first of all educate your clients about why we have emotions. Emotions are like the GPS system which we have. It's like a part of the gut instinct also, where it gives us information about what feels okay and what does not feel okay. Emotions also help us communicate to a partner and parents effectively. It also helps us influence others and so on. It also energizes us and gives us energy to do a certain action. If someone is upsetting me, for example, and I start experiencing anger, the anger will energize me to take an action and make sure that this does not happen again. So emotions basically serve that purpose. So you educate your clients about why we need emotions. Often clients will say that I don't want to feel negative emotions, I don't want to feel unpleasantness, and I want just positive emotions, which is realistically kind of not possible. So to start off with, what we do is we build awareness of emotions. Sometimes our clients don't even have basic skills like naming primary emotions. So we might have to start with that, teaching them how to identify and be aware of primary emotions, learning to differentiate between what is a thought, like for example, I am a failure is a thought, versus the emotion of sadness that comes along with that thought, learning to differentiate between that, and using some of these mindfulness skills that I already talked about to pay attention to those emotions. And if you look at the interpersonal module, we are also learning how to express our emotions effectively. We learn how to talk about them in a manner that retains the self-respect and also we maintain respect of others. Learning how to share emotions and also learn how to listen to other people's emotions. Another important thing here is learning how to read what people actually mean and not reading things literally. So if they've had a fight, in a fight, people lose their temper and they say things they don't mean. So sometimes if the partner says that you're the worst person I've ever come across, they might be reading that, okay, I am this horrible person because of my partner saying that. Whereas what the partner might actually be saying is, I'm so frustrated right now and I don't have the energy for this, that you're pushing me to this extent where I'm having to say something like this. So learning how to read between the lines also is an emotion regulation skill. Another important skill would be conflict resolution, where you learn how to solve conflicts without accusing the other person, but still maintaining your own peace of mind. So that's about your emotion regulation skills. This is often the most difficult part of DBT because clients take a lot of time to master these skills. So one of the best ways of teaching them emotion regulation is every time your client dysregulates in the session, give them just a 2-minute breathing activity where you just ask them to close their eyes, settle in a comfortable position, just do some deep breathing, allow them to experience whatever emotions are happening and regulate them in the session. So here as a therapist, your role is not just of teaching them skills, but also to be a role model of how to regulate every time you dysregulate. So the problem is not dysregulation. The problem is every time you dysregulate, learning the skill to come back to normal on your own. So that's what we are kind of teaching them. Coming to the last module, that is the distress tolerance module. As the term suggests, we already know that clients are extremely aversive to any kind of unpleasant emotion, and small triggers might seem very huge and might bring up a lot of distress, which looks very intense to someone who is not able to relate with that kind of an experience. So generally, if you have a client who is highly suicidal or is parasuicidal and has impulsive behaviors like alcohol, drug use, risky sexual behavior, and so on, that is the time that we use distress tolerance skills. So like we already talked about in emotion regulation, distress tolerance and emotion regulation is often done together, because if the distress tolerance is low and you keep kind of teaching about emotions, they might not be able to learn it by themselves, right? So the goal of distress tolerance is to help them tolerate the emotional pain, but not remove the pain, because there will always be experiences which are painful. So how do you make them sit and tolerate this pain? There are two ways of doing it. One is staying with the feeling. Other is doing the opposite of how you feel. Now, staying with the feeling basically means that if my parent has hurt me, has said something very hurtful, and it's causing me a lot of distress, staying with the feeling means that I'm just going to sit and allow myself to experience the sadness, the guilt, the disappointment, resentment, and I'm not going to do anything about it. I'm just going to sit till the emotion comes, it becomes intense and it comes down on its own. And this comes with the assumption that emotions come with a time limit. They also follow the bell curve. So if you don't interfere with it, you don't overthink it, you don't judge it, it's likely that the emotion will intensify, it will reach a plateau, and it will come down on its own. So the job of the client is to just sit with that pain and allow it to come down and then go about doing other things. So that's one way of doing it. Another way is doing the opposite of how you feel, which basically means that if you're feeling extremely sad and upset and you feel like I can't get out of bed, one of the ways of regulating yourself is to actually get out of bed, because after that you'll start feeling better. Often clients might have difficulty doing both of these, so you might have to experiment a little bit and find out what works for your client. In my experience, I've found that generally clients are better when they stay with the feeling rather than doing the opposite of how they feel, right? Now, in distress tolerance, there are also two specific types of skills. One is crisis survival. So whenever they're encountered with a crisis, we know that the situation cannot be avoided. So the goal of a crisis survival situation is not to make the situation worse. Like, for example, if they've had a fight with the partner, and the partner has said that, okay, I think we have to end the relationship, for example, the goal is not to make the situation worse by calling the partner 100, 200 times, but just to sit down and make sure that you're not engaging in behaviors which make the crisis even worse, right? So that's one part of the skill. Second is acceptance. So the goal is to accept the painful situations rather than avoiding or fighting them. So using the same situation, if the partner said, okay, I don't want to kind of go ahead, and consistently for a period of say 2 months or 3 months, the partner said that, I can't go ahead because of XYZ reason, learning how to accept those painful situations rather than avoiding or fighting it, right? So those are two types of skills that we learn. So one of the ways of also developing distress tolerance is to distract with the wise mind. So telling yourself that I know that this is a painful situation and that probably I did certain things that led to the end of this relationship, and perhaps there are some things which my partner also did wrong because of which this relationship did not sustain itself. So keeping this knowledge in mind, that is with the wise mind, they're able to rate the current level of distress. So you can use a visual analog scale, ask them on a scale of 0 to 10 what is the distress that you're experiencing before and after you do some of these strategies. Now, another strategy to kind of build distress tolerance is whenever you're feeling distressed, allow yourself to feel it, but also distract yourself with activities, certain activities that make you feel good and you like and so on. Contributing in some way, either to yourself or to someone else, helping another person. Not comparing, yourself or your growth or your journey with anyone else. Paying attention to your emotions. Not pushing away, any of these emotions that we're talking about. And whenever you think your emotions are under control, making sure that you're deliberately not pushing them away, but it's like an informed choice. Also paying attention to your thoughts and sensations. So these are some things that can be done with distress tolerance. So largely distress tolerance skills, like in the previous slide I told you, is distracting. That is managing the urges, doing breathing exercises and so on. You can also teach them self-soothing. There are different self-soothing techniques that can be used. Like when you're upset, you can go take a shower, you can go for a run, you can eat something that you like, you can listen to your favorite music. So use all the senses to soothe yourself when you're feeling distressed. So telling yourself that, okay, if I am a young child who is 2 years old and the parents have said, okay, I'm not going to give you chocolate, for example, the child is going to feel upset. But other than the chocolate, there are many other things that parents will do. They'll say, okay, I'm going to show you a favorite cartoon. I'm going to give you this thing that you like, or I'm going to take you out for a walk. I'm going to, help you play with the dog and so on. So you basically substitute experiences through the different senses and help bring down the distress. So the client has to learn some of these self-soothing. Also doing something called improving the moment, which means that whatever is coming in, using half smile experiences, though your experiences might be painful, you deal with them with a half smile, saying that, okay, this is something that is happening and I need to kind of accept it. There's also willingness and willfulness, which basically means that whatever behavior you're engaging in, whatever activity you've chosen for yourself, you're doing it willingly and you're doing it willfully. Like it's a choice that you're making, saying that I am sad and upset, but if I have to come out of this, I need to engage in XYZ behaviors because I know that at the end of it, I'm going to feel better. And also in that moment, thinking of the pros and cons of tolerating distress. So I think we've talked about the crisis survival and acceptance here. This is just a summary of that. So some of the self-soothing skills I've already mentioned here. So the activity you can give your client is to develop a self-soothing kit, which is already ready. So whenever they're feeling distress, is to just reach out to that kit and either look at someone's picture that they like, or listen to their favorite music, or use a fragrance, taste something that they like, touch something that comforts them, and so on. So that's about the modules. I have a couple of slides just on evidence and treatment cycle building and stuff, but I'll stop here for now. If there are questions, I'll take them, and if we have time, we'll probably go over this.
Yeah, it was a nice presentation, ma'am. One person had asked, Michael, like DBT should we use on ourselves?
Yeah.
I didn't understand what.
Yeah. As compared to other theorists and therapists, they don't ask the therapist to do CBT on themselves or supportive psychotherapy. But in DBT, it's almost always a rule that when you're working with such challenging patients, your distress tolerance comes down, your interpersonal effective comes down, because you're constantly in and out seeing these clients. So when I say you have to use on yourself, all these activities which I gave, whether it's mindfulness or interpersonal skills, you have to practice it yourself, in your relationships with your, family, with your professionals, and so on. For the simple reason that the more you practice this yourself, the easier it is going to be for you to also teach your clients to do that. If you are not able to follow some of these things, it might be a good idea to go back and look at what are the things you need to practice first to be able to help your clients. And why I'm saying this is because they're so challenging that they'll test your limits also, whether you are able to kind of do that or not. So a good DBT therapist will also prepare adequately before meeting a client. So if you're teaching your client mindfulness, my suggestion is that 1 or 2 weeks before that, you start practicing yourself so that you know how easy or difficult it is for them to kind of, practice that. So that's what Linehan says, because she says, no matter how good a DBT practitioner you are, you have to constantly keep doing mindfulness yourself, distress tolerance, self-soothing, self-care, because these clients take 2 years to get better. Whereas if you're treating a client with depression, it's very satisfying because within 1 or 2 months, they improve and you also feel a sense of accomplishment. But when you're working with personality disorders, sometimes it takes 2 years, 3 years, 5 years. So that can be very demotivating for a therapist because you don't have reinforcement to kind of, work with those clients. I think there's another question. How to tackle irregularities? That's a good question. So one of the ways to deal with it is when the client comes for the first time is to give an informed consent form where you are mentioning what is the frequency that they're expected to come, how long the session is going to be, what behaviors are going to be tolerated, what behaviors are not going to be tolerated. Like, for example, last minute cancellations are not allowed. So if you're charging your clients, you'll be charging them in advance because that is a commitment that they are making. If you're not charging them in advance, when they do a last minute cancellation, that 1 hour is wasted, plus another client you could have seen is also missing therapy because you gave that appointment with the client. So you will negotiate with your clients and say that if you want to be invested, you have to make the commitment of at least coming to therapy once weekly for 6 months and every month doing advance payment. So if you're doing 4 sessions, you pay in advance for each of these sessions. If there is a cancellation, it has to be 24 hours prior. If there is if there are 2 consecutive no-shows, you will terminate the sessions. And if there are more than 3 last-minute cancellations, you will terminate and you will get back only if they're willing to work with the terms and conditions. Often, many clients who are very dysregulated will not sign the consent form because they are not okay with these boundaries. But don't be scared of setting the boundaries with these clients, because that is exactly what they need. If you don't set the boundaries, you will be the one who's constantly running behind the client, and that's kind of not going to help. Frequency of session for 2 years. So yeah, so overall, if you look at research, research says that if you work with clients once weekly for 2 years, they no longer meet SCID criteria for borderline personality disorder. So which means that in 2 years, you would have completed the DBT-4 modules twice. That's what Linehand recommends. So you do each of these modules twice. So there are different formats. You can just do mindfulness for 3 months, interpersonal skills for 3 months, and so on. Or you can do a combination of all of these. But any form of therapy, whether it's DBT, MBT, or whatever you're using, usually all therapies work. This is better with clients who are suicidal, and once weekly is generally good for about 2 years. So the first 6 months, our task is to just keep them regular, keep them stabilized, and keep them invested, and make sure therapy interfering behaviors are not happening, and that you have a good rapport so that they're coming back whenever there's a crisis, and you're helping them manage that crisis and stabilize themselves. Any other questions?
Sasi PS has raised the hand.
Yes, sir. I'll be sharing the materials with Dr. Vishwas. He will share it with you all. I'll mail it to him. On an average, out of 10, how many patients would have completed this 2-year period? I've had clients who are still seeing me for 4 or 5 years. My experience with clients with borderline personality has been good, except if clients are not either able to afford therapy sessions or they've had difficulty. I would say that out of 10, at least 7, 8 have completed the 2-year period. 1 or 2 are generally very difficult. They'll not even complete 2 or 3 months, and they just kind of drop out. And these are clients who often have not just borderline traits, but they also have other comorbid traits, and they might have OCD, depression, and a lot of that whole spectrum. So it might be difficult for them to kind of get better. Habiba is asking how to deal with transference of a patient towards the therapist. Transference is not necessarily a bad thing. We need a little bit of positive transference to work. So if your client really likes you as a therapist and wants to come and see you and all of that, those are good things. But if this transference becomes negative, for example, it shows that the client has now started projecting some of their fears on you. So the best way to deal with this is, when you start seeing your clients, is to say that sometimes I might share some things, or I might say some things which trigger you and make you upset and angry towards me. So if that happens, please feel free to come and talk to me about it, because it is very natural that in this professional relationship, there might be times that, you might get triggered or upset. So if you talk about it, it's going to help me understand and help you how to regulate yourself. So if you explain to them about transference and countertransference in the beginning itself, it usually helps. And most clients who have BPD are also quite open. They'll just come and say that I was upset that you came 5 minutes late, or I was upset that you said this particular thing in the previous session. So often when you examine it, you have to address it. You can't brush it under the carpet. You might have to say that, okay, when I said that, did I resemble anyone from your early childhood? Or did I respond to you like how your mother responded or how your father responded? How did that make you feel? How does it make you feel that, I am a different person, but then it seems to you that I am also reacting in that same manner? Do you think that this is happening because you're also assuming that I don't have your best interests in your mind, and so on? So best ways to kind of, bring that out in the open. How do you address ego issues? Ramamani, can you tell me what do you mean by ego issues? Because it can be interpreted in many ways. If one is affected because of the partner's ego. See, I think from what I understand of your question, in relationships, there might be one person who's very rigid and one person who is not so rigid. Generally speaking, when there are relationship issues and we are kind of doing DBT, one of the reasons is that clients tend to think that they own their partner. They feel entitled that they can tell their partners what to do, what not to do, and so on. And they might feel that they own the partner and that they can tell the partner what they should, how they should treat them, and so on. So I think we might have to use a little bit of mindfulness skill here and interpersonal skills, where we are telling them that we don't own anyone. We can't tell anyone what they're supposed to do. But what we can do is we can decide what works for us and what doesn't work for us. So we might have to again teach them how to set boundaries and say that, though your partner is giving you so much distress, you're still not allowed to go and tell your partner that, go and tell your partner that, I'm going to be hurtful towards you or I'm going to disrespect, because that's a choice that they are making, right? So I think largely when you're saying ego issues, it appears like someone who is stubborn and, rigidly holding on to what they are saying. But in therapy, we avoid using words like ego because it's used by laymen to suggest that someone is very haughty or arrogant and so on. How to handle ongoing major stressors with therapy. So unfortunately, a major part of your work with clients with BPD will be handling crisis. So you can start doing all your modules, and if there is a crisis, you put the module on hold and you address whatever crisis, like for example, you mentioned breakup, you address whatever issues have happened, but you use some of these skills to learn, to teach them how to come back to baseline. So when we're dealing with a crisis, our lookout is constantly that our client should learn how to come back to baseline every time they move away from it, right? So that's generally how we handle a crisis. And usually you'll find that once you teach your client how to manage the crisis on their own, the intensity comes down, the frequency of these also comes down. So usually it should take about 6 months and you'll find that some of these crisis situations come down. The best time to discuss crisis behavior is when they're not in a crisis. So when they come in a crisis, you should not tell them that, okay, see, you're always coming with a crisis. Last time you came with this time you came with something else, and so on. So that's like a bad timing for that. The best timing is after they have completed whatever problems they've had in that crisis and they have successfully come out of it, is when you can have a conversation and tell them that, you've had a couple of crisis situations earlier and this is how you've dealt with it. So is there something we can do to make sure that you're not in this crisis situation again? So can we have a preventive plan which will make sure that you don't end up in a situation like that? So that might be like a good time to educate them about this crisis.
I think there are 2 more questions in the question and A.
Yeah.
Question and answer section.
Yeah.
Regarding, kindly give me more information about the crisis survival asked by Anupama.
More information on?
Crisis survival she has mentioned.
Crisis survival. Okay. Okay. So basically, crisis survival, what we are doing is we are teaching them how to stay with the emotion. I think I'll also show you the slide so that it becomes easy. Right. So if you look at this left section, when you're in a crisis, the goal is to not make it worse. So if you've had a breakup, is to not make sure that you're not making it worse for yourself or for the other person. So you can use this wise mind accepts, which I showed you here. You can use any of these activities to basically help them during a crisis. They also teach them how to self-soothe, because crisis can be painful. You tell them that they deliberately need to engage in activities which make them feel good about themselves and which calm them down. Also, in the movement, they can use half smile or willfulness or willingness to kind of accept the situation that there is only so much that they can do, and also engage in certain creative activities till the crisis comes down on its own. So basically, what you're teaching them is when there is a crisis, just learn how to take care of yourself. Once the crisis comes down, then you can kind of address some of the other issues that are there. Afra says, you mentioned about modules and boundaries. Okay, all right. So usually, in the beginning, when your client comes and asks you, like, what is therapy? How frequently should I come? What must I do? And all of that. So you will discuss how frequently you'll see them, like once a week. You'll see them for 45 or 50 minutes. And you cannot extend the sessions. And if they come late for the session, you're not going to see them beyond the time. So if your slot is 10 to 10:45, if they come at 10:30 and say that now you see me for 45 minutes, that is something that won't happen. If they cancel the session, then you won't reschedule for some other day. You'll fix a day and time, like every Tuesday 10 to 11. So if they miss this Tuesday, then they'll be coming only next Tuesday. And when it comes to scheduling sessions, like I said, if there is a cancellation, they have to give you 24-hour notice. And they have to, if they want to book a session, they have to pay 24 hours in advance to book that slot. And if they don't turn up, then there won't be like a refund. This will basically help to discipline the client to this whole therapeutic process and make sure that they're not actually taking advantage by saying that I'm not well or things are not okay and so on. So by doing these things, we are teaching our clients to take responsibility for their mental health and also commit to the psychotherapy process. Right? So that's what you do. What is the best time to include family members in therapy? Ideally speaking, when you're doing individual therapy with a client, if you start seeing family very early, they might feel invalidated because family will come up and say things which they might not like and so on. So good idea is to first see your clients for the first 3 months, if possible 3 to 6 months, where you build a good rapport. And the first way to include family members is to not see the family members alone. Always see the family members along with the client so that the client retains the trust in you. And whenever you have a session with the family members without the client, you will first see the client for 10 minutes. You will ask them and talk to them about what all you'll share with the family. You'll share and discuss and talk. And then in the last 10 minutes, you'll see the client again and give them an update of whatever was discussed. So in this way, what you're doing is you're supporting the client and you're also retaining that trust rather than actually, involving the family as one extra variable, which can actually throw the entire interpersonal and individual relationship you have with the client. Typically, if you ask me, the best thing to do is the individual therapist should never see the family, but another therapist should be seeing the family, and the therapist should just discuss amongst each other as to what is happening. That way, we can ensure that the client does not feel validated, but we know that in the Indian setting, that's not how it works. Family is always involved in therapy. So the first method, which I told you, is best if you're doing it with Indian clients where family wants to be involved. So you negotiate and tell them that I might have to talk to them. So you can tell me what are things I should discuss with them and not discuss. There are also certain DBT skill group manuals for family members and caregivers and all that. So you can go back and read if you're interested. Is there any treatment modality for patients with suicide attempt and borderline personality attending OPD but not billing for full-term DBT? Unfortunately, the answer is no. If they are on medication, that might be the only thing that helps. But if they're not willing to do DBT, then something as simple as something simple that you can give them is making sure that they're working out every day so that there is at least some natural antidepressant that they have, that they're engaging in at least mindfulness and distress tolerance. Like you can negotiate with them and say that come just, once in 2 weeks and just learn one skill like mindfulness and one distress tolerance skill and see how that goes. But that won't be an adequate dose of treatment. So they might not actually improve. So you might have to tell your client that if you're not willing to do full-term therapy, at least for 3 to 6 months till you stabilize, unfortunately, you're not going to feel better. And once there is a crisis, you're going to again come back. So you either have the option of kind of doing it now, or you can come back whenever you're ready, because there's only so much we can do. We can't, DBT skills are not things we can teach them on an OP basis, unfortunately. Okay, any last question? I think someone's also asked about laying out boundaries and how to cancel session and rules. Yeah, I think I mentioned that. I'll send you some of these formats. You can just take a look. Dr. Vishwas will later share them with you. That will give you some base.
Yeah, I will share. Them.
All right.
Yeah.
So, thank you, ma'am. It was a nice session and very well taken by the audience.
Thank you.
Thank you once again.
Thank you.
What